So we had covered the brachial plexus, and just to revise for you, the brachial plexus was formed from 3, 4, 5, 6, 7, 8, 1 roots. The 5, 6 formed the upper trunk, the 7th the middle trunk, and 8, 1 the lower trunk. They divided into the anterior and posterior divisions, all trunks. The anterior division of the upper and the middle trunk formed the lateral cord, and the anterior division of the lower trunk formed the medial cord, and the posterior division of all the three trunks formed the posterior cord. The lateral cord continues into the musculocutaneous nerve, the posterior cord into the radial nerve, and the medial cord into the ulnar nerve. And a fourth nerve arises from both the lateral and medial cord, which we call the median nerve. The branches of this brachial plexus were 3, 4, 5 phrenic, 5, 6, 7 nerve to serratus anterior, 5 is common, which is dorsal scapular, and 2 all scalene muscles, and all rami communicants. So all roots would do this. And these were the branches from the roots. From the trunk, from the middle trunk, there was the suprascapular nerve and nerve to subclavius. And we were to continue at the level of the lateral, posterior, and medial cord. So, the lateral cord, so we are now going to talk about the branches from the cords. You have seen that there is a lateral cord, there is a posterior cord, there is a medial cord. The lateral cord has continued into the musculocutaneous, the posterior cord into the radial, and the medial cord into the ulnar nerve. Then from the lateral and medial cord has arisen the median nerve. Therefore, 3 cords, 4 nerves. And now we are going to place the other branches of the cords. So this is the lateral cord, this is the posterior cord, this is the medial cord, and from the lateral and medial we place the lateral and medial pectoral. From the medial cord additionally we place the medial cutaneous nerve of arm and forearm, medial cutaneous nerve of arm and forearm. So first we place the lateral and medial pectoral. Then we place the medial cutaneous nerve of arm and forearm. And from the posterior cord, we place the upper and the lower subscapular, supplying the subscapular muscles, the upper and the lower subscapular, the nerve to latissimus dorsi, and the axillary nerve. So these are the additional branches from the cord. To repeat, First say lateral medial pectoral, lateral medial cords. Then from the medial add additional medial cutaneous nerve of arm and forearm. And then proceed to say from the posterior cord, upper, lower, subscapular, thoracodorsal or nerve to latissimus dorsi, and axillary. Now we'll place these nerves in a diagram so that you can basically understand their position. So you would draw the scapula, the glenoid cavity, the supraglenoid tubercle, the coracoid process, the suprascapular notch, the upper border of the scapula, the medial border of the scapula, the lateral border of the scapula. We will draw the head of the humerus, the greater tuberosity, and the shaft of the humerus. From behind would come the acromion, the spine of scapula, and would convert into the acromion process. Will convert into the acromion process. I have drawn it dotted. It'll divide the posterior space into a supraspinous and infraspinous portion. Then we'll place the tendon of the biceps. From the supraglenoid tubercle and the coracoid. So this will become the biceps, the biceps tendon, coracoid process. The two heads of the biceps. We'll place another muscle from the coracoid process, that is the coracobrachialis. And under the biceps, we'll place the brachialis. So this is the brachialis, this is the biceps. Then as we go down, this divides into a lateral and a medial epicondyle. On this side is the capitulum, and then you have the trochlea. And from the from this lateral epicondyle arises the brachioradialis muscle, supracondylar ridge and lateral epicondyle. And it goes and gets inserted into the radial styloid. Go and get inserted into the radial styloid. So here there will be a groove between brachialis and brachioradialis. The brachialis will go and get inserted into the coronoid process of the ulna. So there will be a groove between brachialis and brachioradialis. Okay. Then we will place the lax part of the capsule. We'll place the teres minor muscle behind it. And we'll place the subscapularis muscle in front of it, in front of this lax part, going to get inserted into the lesser tuberosity. So here will be the lesser tuberosity and the bicipital groove. So this subscapularis will get inserted here. Then will be the teres major, like this, going to get inserted into the medial lip of the bicipital groove, the medial lip, the teres major, and the long head of the triceps lying in front of the teres minor, but behind the teres major, would form the quadrangular and the triangular space. So this one is the lateral triangular space, this one lateral triangular. This one is the medial triangular, and this one is the quadrangular space. Okay. Now we'll place the nerves. The lateral cord gives a lateral pectoral which supplies the pectoral minor, and the medial pectoral which supplies the pectoralis major and minor both. Then the lateral cord continues as the musculocutaneous. It pierces the coracobrachialis, supplying it. It lies between the biceps and the brachialis. In the groove between the brachialis and brachioradialis, pierces the deep fascia as it crosses the elbow and becomes the lateral cutaneous nerve of forearm. So we'll put all these steps. Musculocutaneous starts as lateral cord, pierces coracobrachialis, lies between brachialis and brachioradialis, supplying both, then lies between brachialis and biceps on the medial side and brachioradialis on the lateral side. So first it lies between biceps, brachialis and biceps. Then it lies between brachialis and brachioradialis. Here it lying between brachioradialis and brachialis. Then it pierces deep fascia and becomes the lateral cutaneous nerve of forearm. So this finishes the musculocutaneous. The lateral and the medial pectoral. Lateral pectoral supplies only the pectoralis major. The medial pectoral pierces the pectoralis minor and supplies pectoralis major and minor both. The lateral pectoral pierces the clavipectoral fascia, therefore it supplies only the pectoralis major. But the medial pectoral would supply the pectoralis major and minor both. So the medial pectoral and lateral pectoral we've placed. Then the medial cord. The medial cord continues as the ulnar. But it also gives the medial cutaneous nerve of arm and forearm, which pass into the arm, pierce the deep fascia near the elbow and become the medial cutaneous nerve of arm and forearm. The ulnar nerve passes into the arm, pierces the lateral intermuscular septum in the middle of the arm, and becomes posterior into the arm. Then, so ulnar nerve, continuation of medial cord, enters the arm, pierces medial intermuscular septum in the middle of the arm, so it lies in the arm medial to artery. And then you must remember this diagram. Looking to the elbow from the medial side, this is the medial epicondyle. Here you can see the trochlea. Then you can see the olecranon and the coronoid. Then we have placed the posterior part of medial collateral ligament, and we have originated the flexor carpi ulnaris muscle from the medial epicondyle, the posterior part of ulnar collateral ligament, the olecranon, the upper 1/4 of posterior border of ulna. So this is the flexor carpi ulnaris muscle. So as the under the flexor carpi ulnaris, originating only from the ulna, is the flexor digitorum profundus. So this is the flexor digitorum profundus. The ulnar nerve lying between the medial intermuscular septum and the triceps. Triceps would be getting inserted in the olecranon. So this nerve lying between the intermuscular septum and the triceps will pass under the posterior part of ulnar collateral ligament. Very, very important. Come to lie under the flexor carpi ulnaris and superficial to the flexor digitorum profundus. At this point, the ulnar nerve will supply the flexor carpi ulnaris and half of flexor digitorum profundus. That means the part of flexor digitorum profundus going to the third and fourth fingers will be supplied by FDP of the third and fourth will be supplied by the ulnar nerve. Now this space which we'll try to show you in a section. Here is the trochlea seen from above. Here is the medial epicondyle. Here is the olecranon, the posterior border of ulna, seen in a section. Here is the capitulum and here is the lateral epicondyle. So this is lateral, this is medial. Okay. Now I told you that the ligament, ulnar collateral ligament, lies like this. It starts from the medial epicondyle and goes to the olecranon. and here you will be having the capsule of the elbow joint. So this space posterior to the medial epicondyle, medial to the trochlea and the olecranon and the elbow is the canal of Cannon, and the nerve is lying in this canal of Cannon. As the flexor carpi ulnaris originates from the medial epicondyle, from the canal of Cannon, from this posterior part of ulnar collateral ligament, and from the olecranon, the nerve would come to lie under this flexor carpi ulnaris. So it will come to lie here. And when there is leprosy and swelling of the nerve, it is in this canal of Cannon that this nerve would get compressed, and you have to detach. You have to detach this medial epicondyle and open the canal of Cannon to decompress the ulnar nerve at this site. Continuing with the ulnar nerve, further continuing with the ulnar nerve, we'll say that 5 centimeters above the wrist, it gives a palmar carpal branch, which passes superficial to the deep fascia, crosses the wrist, and supplies the skin over the hypothenar eminence. And the palmaris brevis muscle. So this finishes the course of the ulnar nerve in the forearm. Now we come to the wrist. So if we want to draw the wrist, we have the radius, we have the ulna with the ulnar styloid, we have the scaphoid, lunate, triquetral, and pisiform bone here, and we have the trapezium, trapezoid, capitate, and hamate with its hook here. So the flexor carpi ulnaris muscle, which has such a important origin, would come and get inserted into the pisiform bone. And then it will send a ligament which is called as the pisiohamate ligament. The nerve lying medial to the flexor carpi ulnaris, lateral to the flexor carpi ulnaris, will come, and as it comes here near the pisiform, it divides into a superficial branch and a deep branch. The deep branch will pass under the pisiohamate ligament, and it can get compressed here if it swells during leprosy. So this canal through which the deep branch passes is called as Guyan's canal. The superficial branch will lie superficial to the palmar aponeurosis, supply the 1.5 of the third and fourth finger. simply means that if this is the little finger and this is the ring finger, the nerve would come here, it will supply this, then it will go into this web space supplying this and this. And it will also communicate with the superficial branch of the median nerve. So this is the course of the superficial. Now the deep nerve, we'll draw the rest of the metacarpals to understand this. So this is the one, this is the fifth one, the fourth, the third, the first, the second, and the fifth metacarpal of the hand. And here you have the three phalanges, one proximal, intermediate, and distal, and the thumb has got only two phalanges, 1 and 2. Now I told you that there is the abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi. Then there are the intraossei, and here you have the adductor from this metacarpal. And you have this flexor digitorum profundus tendon. So this is the flexor digitorum profundus tendon. And this flexor digitorum profundus tendon is giving a lumbrical muscle. So this nerve basically passes between abductor digiti minimi and flexor digiti minimi, pierces the opponens, supplies all intraossei, the third, fourth lumbricals, and ends in transverse head of adductor pollicis. So we'll state it again. The deep branch passes between abductor and flexor digiti minimi, pierces the opponents digiti minimi, arches just anterior to the intraossei, supplies all intraossei, third, four lumbricals, and ends in the transverse head of adductor pollicis. So, if we want to find out what will happen if the ulnar nerve is paralyzed, so what will be the effect? The flexor carpi ulnaris will be paralyzed. Therefore, palmar flexion, ulnar deviation will be lost. Of the wrist, palmar flexor carpi ulnaris is palmar flexion, ulnar deviation. Simultaneously, there will be wasting. Then the FDP of the third and the fourth fingers will be paralyzed. Therefore, distal IP joint of the third and the fourth fingers cannot flex. And this decreases the claw hand deformity. See, claw hand means this is the metacarpal, this is the first phalanx, this is the second phalanx, and this is the third phalanx. So this is the claw hand. Extension at MP joints, flexion at PIP and DIP joints. Now here, since the flexor digitorum profundus is paralyzed of the third and fourth finger, this will not flex and the deformity, claw hand deformity will decrease. And this happens in a higher paralysis, high lesion, where the lesion is in the canal of Cannon. Therefore, this is called as ulnar paradox. Normally, higher paralysis should cause more deformity. But here, the higher paralysis is decreasing the claw hand deformity. Higher paralysis decreasing the claw hand deformity because of inability to flex the DIP joint. This is ulnar paradox. Higher paralysis decreases claw hand deformity because the DIP joint, the distal interphalangeal joint, cannot flex. So this is the effect of a high paralysis in the canal of Cannon. Now, let us talk about the paralysis where the compression is in the Guine's canal. You see, the superficial branch of the ulnar nerve would not pass through the Guine's canal. Therefore, sensations may be spared. But abductor, flexor and opponens digiti minimi will be wasted. And if you test the abductor, enable to abduct little finger at MP joint. This is said to be the Guava's test. Then the third, fourth lumbricals will be paralyzed. Lumbrical. What does the lumbrical do? If this is the metacarpal head, the lumbrical would flex at the MP joint, flex at the MP joint, and extend at the PIP and DIP joint through the extensor expansion. This is the flexor digitorum profundus tendon. Here is the flexor digitorum superficialis tendon. It's dividing into two and supplying and flexing the PIP joint. And here is the extensor digitorum longus tendon, dividing into an extensor expansion, inserted like this and like this across, extending both interphalangeal and PIP and DIP joints. So it flexes. This is the extensor digitorum longus tendon. Now what does the lumbrical do? Lumbrical arises from the flexor digitorum profundus and attaches to the extensor expansion. So this is the extensor expansion. So this lumbrical will flex the MP joint and will extend the PIP and DIP joint. Supposing it gets paralyzed, the MP joint will hyperextend, and the PIP and DIP joint will flex. So the finger will become clawed. So this is the clawing of hand is the paralysis of lumbricals. Clawing, third and fourth finger. Then intraossei are paralyzed. And the intraossei function is pad, dab. So, if this is the thumb and these are the fingers, you place a card between the fingers, and ask the person to hold this card by adducting the adjacent fingers. If he can't hold that card and you are able to pull out that card, it is called as the card test positive, and it indicates paralysis of palmar interossei, palmar interossei adductors. Okay, so these are the interossei, and then you have the adductor pollicis. And what you do, that the adductor pollicis would adduct the thumb. So you place a book here, and if he can hold, and you are trying to pull this book out, and if you can hold this without flexing this joint, without flexing the IP joint of the thumb, he should not do this. He should do this only. And this is called as Froment sign positive. Flexion of the IP joint of thumb while holding a book is called as Froment sign. And this is the test of adductor pollicis. And it is also called as the book test. So what are the effects of paralysis of the ulnar nerve? The effects are of high paralysis, where the nerve is compressed in the canal of Cannon, or low paralysis, where the nerve is pressed in the canal of Guion. The high paralysis paralyzes the flexor carpi ulnaris, causing wasting and weak palmar flexion, ulnar deviation of the wrist. The third and fourth flexor digitorum profundus paralysis causes failure to flex the distal interphalangeal joints of the third and fourth fingers, so that the claw hand deformity is reduced in a higher paralysis. So reduction of deformity in a higher paralysis is called as ulnar paradox. Then the low paralysis is wasting of the hypothenar eminence, positive weakness of the abductor digiti minimi, paralysis of the third, fourth lumbrical, leading to extension of MP joint and flexion of PIP and DIP joints, which is called as the claw hand. Paralysis of the interossei, where palmar interossei are adductors, distal interossei are abductors. So the card test becomes positive, and paralysis of adductor pollicis, so that to hold the book, he will use the flexor pollicis longus by flexing the interphalangeal joint of the thumb. This is called as the book test or the Froment sign positive. So these are the signs of ulnar nerve involvement. We'll cover the median and the radial nerve next time.